Hello, everyone, and thank you for joining us for today's webinar. We will be learning about FQHC coding and documentation. The webinar today is being recorded and will be posted to our website. We will send the recording and the slides to all participants at the end of the series. My name is Latrell Courtney, and I am the Clinic Consultation Specialist with the National Rural Resource Center, which is providing this webinar today. This webinar series, qualifies for a CHE credit. Caleb Lazinski will be sending out an email after the final installment in this series with a link to receive credit. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located on the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we can know who is joining us today. This helps us get a good feel of the audience on the webinar. The National Rural Health Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about our commitment on our website. Please join us for these upcoming webinars. We have the DRCHS webinar for HCC Risk Adjustment Update on August the 24th at 11 Central. We also have the Telehealth Insights Post-PHE, August the 31st at 11 a.m. Central. Before I introduce our speakers, Caleb Lazinski will be pulling up the polling questions. The polling questions is rated on a confidence scale and help us measure knowledge gained on today's webinar. Now I will introduce today's speakers. We have Caroline Gallman Hernandez. She is a senior consultant of Forbes Healthcare Performance Improvement. She has 5 years of experience in coding compliance, denials, and revenue cycle. Caroline began her career with a large clinical staffing and revenue cycle management company where she obtained experience in claims processing, process improvement, data analysis, ICD-10-CM coding, AMA HCPCS, CPT coding, insurance provider rules and regulations, and revenue cycle procedures. We also have Stacy Gee. Stacy is a member of Forbes Healthcare Performance Advisory Services Division and focuses on hospital revenue cycle services. She is an experienced healthcare consultant with many years of experience in assisting the operational and financial performance of healthcare facilities. Her past role as a department manager in a healthcare organization helps her identify and relate to the daily challenges presented to clients. She has experience in billing skilled nursing facility services as well as long-term care services. I will now turn it over to our presenters.
Hi, thank you very much. I'm Stacy Gee. Caroline and I both are going to be kind of going through this presentation. So I just wanted to say good morning or good afternoon, depending on where you are. I am in central Oklahoma, and I was just checking the temps. It's 88 degrees outside. We will take that for mid-August any time of the day. So excited about those 80-degree temperatures. So let's get started. We are going to talk about, I know we've already had the introductions. We're going to kind of talk through what is an FQHC, what kind of services can be provided within the FQHC world. We're going to talk a little bit about claims and billing, We will have some examples of some claims to talk through and walk through, and then we're going to talk a little bit about reimbursement and payment. So if you have any questions, just drop them in the chat. We will address them as we go if we have time. If not, we can address them afterwards, kind of like we did last week. So feel free to drop any questions in. Okay, so what is an FQHC? So an FQHC is also known as a community health center. It's a primary care center that is community-based and patient-directed. So some of you might ask, what does that mean, patient-directed? So whereas center or person-centered type care would focus on the whole person, maybe not just the medical conditions, in patient-directed care, the approach puts the individuals in control of the decisions about their care. So just a little side note there about patient-directed care. FQHCs provide preventive services to vulnerable populations that would otherwise not have access. A lot of rural areas, low populated areas, and so forth. And then FQHCs provide services to all individuals, regardless of their ability to pay, and they offer a sliding fee discount scale to those eligible patients. So to qualify as an FQHC, there's some requirements that must be met in order to make that qualification. You can get a grant under Section 330 of the Public Health Service, or is funded by the same grant contracted to the recipient. You can not get a grant under the Section 330 of the PHS Act, but the Secretary of the Department of Health and Human Services, which is HHS, that allows such a grant, which then qualifies the entity as an FQHC lookalike. So we've got FQHC and then we've got FQHC lookalikes. And these are based on the HHS recommendations. FQHCs are treated by the Secretary of HHS as a comprehensive, federally funded health center. And then they operate as an outpatient health program or facility of a tribe or tribal organization under the Indian Self-Determination Act, or as an urban Indian organization getting funds under Title V of the Indian Healthcare Improvement Act as of October of 1991. They operate under a consumer board of directors, governing structure and function under the supervision of the of the Health Resources and Services, which is HRSA, which is a division of the United States Federal Department of Health and Human Services. So those are some of the qualifications for FQHCs. So if you meet those qualifications, the FQHC certification requires the entity to meet all of these requirements. So they must provide comprehensive services, have ongoing quality assurance program, including an annual review. They must meet all health and safety requirements put forth. They cannot be concurrently approved as an RHC. So in my mind, I think of RHCs or rural health clinics and FQHCs as cousins almost. They're very similar, but there are very different billing guidance and requirements, but they are very closely similar. And then an FQHC certification must meet all of the requirements in Section 330 of the PHA, including serving a designated medically underserved area, which is MUA, or medically underserved population, which is MUP. They must offer a sliding fee scale to people with incomes below 200% of the federal poverty guidelines. And then they also are governed by a board of directors where the majority of members get care at the FQHC. Okay, so what qualifies for an FQHC visit? So the visit must be medically necessary. It must be face-to-face with a medical or mental health qualified must be face-to-face with a mental or medical qualified healthcare professional. And it can be a qualified preventive health visit. So when we talk about FQHC practitioners, those include physicians, NPs, PAs, CNM, which are certified nurse midwives, CPs, or CSWs. And in certain situations, can include a registered nurse or a licensed practical nurse visit to a homebound patient. And then under certain circumstances, a qualified practitioner can give outpatient diabetes self-management training or medical nutrition training services when the FQHC meets the relevant program requirements to provide these services. And there's a whole list of requirements to be able to provide those DSMT and MNT services. The Association of Diabetic Care and Education provides a very robust list of what those requirements are, if anyone has any interest in looking in that. So the eligible providers that we just touched base on a little while ago. So who's qualified to be an FQHC provider? So a physician, excuse me, whether it's an MD or a DO, nurse practitioners, physician assistants, clinical psychologists, certified nurse midwives, clinical social workers, which also includes the DO we talked about, dental surgery, dental, medical, podiatry, optometry, and chiropractic. So these are typically the types of providers that we'll see in the FQHC settings. So just kind of outlined them there for you. Okay, so what are FQHC services? So they are physician services, services and supplies incident to a physician service. It will also cover services of those NPs, the PAs, the CNMs, CPs, and the CSWs, and the services and supplies considered incident to the services of those. Visiting nurse services to confined patients at home. And when we talk about those visiting nurse services for those patients that are confined, there are some very specific requirements. The patient has to be considered confined to the home. The FQHC has to be located in an area that has a shortage of home health agencies. The services and supplies are provided under a written plan of treatment. The nursing services are furnished on a part-time or intermittent basis only. And then drugs and biological products are not provided. So there's some very strict guidance when we talk about these visiting nurse services to patients confined at home. FQHC services also include certain care management services, like chronic care management, transitional care management, certain virtual communication services, your IPPEs, which are your initial preventive physician exams, your AWVs, which are your annual wellness exams, and then the outpatient diabetes self-training management and the medical nutrition therapy that we talked a little bit about earlier. So where can an FQHC visit take place? So obviously within the walls of the FQHC, also at the patient's home, including an assisted living facility, in a Medicare covered Part A SNF or skilled nursing facility, at the scene of an accident, or in a hospice facility when the FQHC provider is employed or working under contract for the FQHC, but isn't employed by the hospice program. So just a little caveat there on the hospice piece. So where can FQHC visits not take place? They can never happen in an inpatient or outpatient hospital department, which includes a critical access hospital facility, or a facility with specific requirements that exclude FQHC visits. So let's talk a little bit about payment codes and qualifying visits. So on each claim, there's a list of qualifying visits that have been published by CMS. And there is a list of payment codes that FQHCs are required to visit or to report on a claim. So on a claim, we would expect to see one service line per encounter visit with a revenue code 520X and a qualifying medical visit from that qualifying visit list. So we will get just a little bit more into detail as we go through these next few slides, but there are, I believe, five payment codes that are required to be on a Medicare claim, in addition to any other services that are provided during that encounter. And there are a published list of qualifying visit codes. I've attached the link here to that document that shows you the payment codes as well as the qualifying visit list codes. The next slide is an example. This is what you'll see, and this is not an inclusive list. This is literally just a snippet that I took. So when we talk about the FQHC payment codes, that's going to be the G0466, which is an FQHC visit for a new patient. And then you can see below the CPT HCPC codes to your left, and then the qualifying visits. So any of these codes that you see in this column on the left that says HCPCs, these are codes that are going to qualify to be reported with the G0466. And again, this is not an inclusive list. This is just a snippet that I took to kind of fit on this slide. So if you report a claim, or if you submit a claim to Medicare with 92002, which is an eye exam for a new patient, the expectation is on that same claim, you're going to see the payment code of G0466. So just a kind of a visual there. Okay, so these are the FQHC payment G codes. We've got the 5, we've got the G0466, the G0467, the G0468, which is for your IPPE and your annual wellness, the G0469, which and the G0470, which are your mental health. So you can see at the top the G0466 and the G0467, those are your medical visit payment codes. You've got one for a new patient, one for an established. The G0468 is going to be your IPPE and your or your annual wellness visit. And then the G0469 and the G0470, those are your payment codes for your mental health visits for both a new patient and an established patient. So let's just talk really quickly about the G0466. This is the FQHC payment code for a new patient. And the requirements to report this G0466 has to be a medically necessary face-to-face encounter between a new patient and a new patient. We'll talk a little bit further down what's the difference between a new patient and an established patient. So between a new patient and a qualified FQHC provider. A new patient is one who's not received any professional medical or mental health services from any practitioner within the FQHC organization or from any other sites within that FQHC organization within the past 3 years prior to the date of service. To qualify as an FQHC visit, the encounter must include one of the service codes listed under that qualifying visit list that we were just looking at. And these are the CPT or HCPC codes that correspond to a specific payment code. So just an additional tidbit here. If a new patient is also receiving a mental health visit on the same day, the patient is considered new for only one of those visits. And the FQHC should report G0466, which is the new patient, to bill for the medical visit, and then G0470 to bill for the mental health. Okay, G0467, this is the FQHC payment code for established patients. And when we talk about established patients, this is a patient who has received professional medical or mental health services from any practitioner within the FQ organization or from any of the sites within that FQHC organization within 3 years to the date of service. Again, we would expect to see the G0467 in addition to one of those qualifying visit codes from the qualifying visit list. And then we've got the G0468. This is going to be your payment code for your IPPE or your annual wellness visit code. And I believe right now for Medicare, there is a G0438 and a G0439 for the annual wellness visits. The G0438 is the initial and the G0439 is the subsequent visit. So if you are providing an annual wellness visit, we would expect to see G0468 in addition to those other codes on the claim as well. Okay, then we have G0469. This is a mental health new patient. Again, the same guidelines, criteria in identifying a new patient versus an established patient. So to qualify as an FQHC mental health visit, the encounter must include a qualified mental health service, such as a psychiatric diagnostic evaluation or psychotherapy. And again, if a new patient is receiving both a medical and mental health visit on the same day, the patient is considered new for only one of these visits. So you would report a new visit code for one of the encounters and established for the other. Okay, G0470 is the mental health established patient. And again, just making sure that we are able to identify and accurately assign if it is a new versus established patient. And as we get down further within the presentation, we're going to talk a little bit more in detail about behavioral health visits, those CPT codes, how they align with your payment codes and so forth. So more to come on the mental health codes. Okay, so the FQHC bill types, they're very similar to the rural health clinic bill types. You're going to identify that type of bill as being an initial bill, or if it's an adjustment that you're making to a claim that's already been submitted, or if you're going to void or cancel a claim. So your initial bill is going to be a 0771. Your claim adjustment is going to be a type of bill of 0777. And if you're voiding or canceling a claim, that's going to be a type of bill of 0778. Your dates of service cannot overlap calendar years, and CMS calendar year starts October 1. So you cannot have dates of service from September the 29th through October the 2nd. That overlaps that CMS year. So you have to separate your September dates of service from your October dates of service. Okay, these are applicable revenue codes. And it just kind of just a quick reference that kind of helps identify quickly the service lines that we're looking at. So 0521 is typically what we see on most of the FQHC claims when we're doing any kind of review or assessments. 0521 is what we're going to see, but you can see there are some other ones. There's for example, 0528, which is a visit by an FQHC provider to other non-FQHC site, for example, the scene of an accident, when we were talking earlier about acceptable locations for an FQHC visit. This one would apply to that if it's the scene of an accident. And then you've got your drugs, 0250, and then behavioral health. Any kind of behavioral health service is going to be reported with that revenue code of 0900. Okay, so new versus established. So a new patient, and these are the CMS guidelines that have been published in regards to new versus established. So a new patient has not received any professional medical or mental health services from any sites within the FQHC organization. And that can mean if you have other sites that are affiliated or fall up underneath that umbrella of your FQHC organization within the past 3 years. If a new patient is receiving mental health services and medical services on the same day, the patient is considered new for only one of these visits. So that's a key thing to remember. Also, having a good understanding of new versus established in regards to if providers move around from various locations. They may see a patient in clinic A and then for some reason, or travels to clinic B or clinic C to provide services and sees that same patient. If it's within that 3-year time frame, that patient, even though that patient may never have been seen in clinic C, if Dr. Smith saw that patient in clinic A and then goes and sees that same patient in clinic C, that patient is considered an established patient. Even though the location may be new to that patient, the provider is not. Okay, so let's talk quickly about multiple encounters, same day. So modifier 59 indicates that separate conditions on the same day or on the same treatment day are unrelated. So the example that we like to use is I come in the morning for just a routine, regular medical visit. I'm seen, let's say at 10 o'clock in the morning. And then later that afternoon, 1, 2, 3 o'clock in the afternoon, I fall and I have pain in my hip, or I have pain in my elbow, or something that kind of forces me to come back to the clinic to see the provider, then that's considered two separate encounters. And we're going to drop that modifier 59 on the subsequent. So the initial encounter that for the morning goes on the claim. And then when I come back in the afternoon for that subsequent or that second visit, that's also going to be on the same claim. And we're going to attach that modifier 59 to that second or that subsequent service line. And I've kind of got an example here on the next slide, just kind of what would that look like on your claim. So you can see the first line, I've been in for my office visit. I'm an established patient with a level 3 E&M assignment code. So the 99213, that was for my morning visit. Also for that morning visit is the G0467, which is the established medical visit payment code, which is required to be on the claim. And then I came back later this afternoon for laceration repair. And you can see that we are attaching that modifier 59 to that subsequent visit. So you're not going to put a 59 on both lines. You're literally just going to put it on that second or that subsequent line. Okay.
And Stacy, just real quick before we talk about this slide, someone asked a question. Does this modifier also work for a behavioral health visit on same day as a medical visit?
I believe so. Yes. Yeah.
Thank you.
Sure. So yes, I was just looking at my notes here. So this modifier 59 is applicable if the patient has a medical visit and a behavioral health visit on the same day. So there we go. And or it's also applicable if the patient has an IPPE visit and a separate medical and or separate behavioral visit on the same day. You're going to apply those 59s. Okay. I hope that helps. Okay, so this is again mental health and medical visit on the same day. I don't have the 59 on here. What I was more focused on this particular one was looking at the payment G codes and making sure that we can see this person came in, had an annual wellness visit, and also came in and had psychotherapy for 30 minutes. So we can see the G0468, which is your payment code, and the G0439, which is your annual wellness visit code. Then this patient also came in and had psychotherapy, which is the 90832, and then the G0470. So just making sure that we understand two separate encounters for two different, mental health and medical. We would expect to see the applicable payment G codes assigned for those visits.
We had another question come in about modifier 59. Does that modifier work with CCM?
So CCM, that's a very good question. I think my initial gut tells me yes, but let me write that down and do some research on that. Okay, that is a very good question. Make my notes here. Okay.
So now I think we're going to dig into a little more of the behavioral health side. A lot of this is some information we've already talked about, but we do get into a little bit more detail. So some eligible FQHC behavioral health providers are your clinical psychologists, so those that hold a PhD, a licensed clinical social worker, of course, any type of physician, so an MD, a DO, A licensed clinical professional counselor or a clinical professional counselor is generally not payable by Medicare. So our note here is to just check with your home state to see if an LCPC or a CPC are eligible. In most states, they are not, but there could be, you know, an outlier somewhere where they do accept them. So your mental health visit, I know Stacy touched on this previously. A mental health visit is strictly just a medically necessary face-to-face encounter between an FQHC patient and an FQHC practitioner, during which time one or more FQHC mental health services are provided. Important to note here that group mental health services do not meet the criteria for a one-to-one face-to-face encounter. So to dig a little bit deeper into those behavioral health qualified visits, the G0469 is the FQHC mental health visit for a new patient. So that will always need to be assigned if one of these subsequent CPT codes is added to the claim as well. So if the patient comes in for that initial psych diagnostic evaluation for 90791, you would want to see that G0469 on there as well, as long as they are a new patient. And I do believe, I know the list that Stacy had earlier was just like an excerpt. I do think this is all of the behavioral health codes, right, Stacy? Yeah.
Yes, it is.
So G0470, again, this is an FQHC mental health visit specific to an established patient. So if the patient is coming in for like a psych eval and they also are treated for some type of medical services, they'll assign that 90792 with the G0470. So this slide is just an example of what your claim should look like or typically look like. Behavioral health services performed by a qualified healthcare provider are billed with the rev code 0900. So obviously the 90832, which is the psychiatric visit with patient and family for 30 minutes, billed along with the G0470, which is the established mental health FQHC visit. So the importance of correct coding, correct coding is important regardless of the facility setting. If you're an RHC or an FQHC, the coding is there to reflect the true health of the patient. So the diagnosis code needs to correlate with the or to the CPT or HCPCS coding. All payers tend to reimburse differently, so it is very important to accurately code and report services to the most accurate and specific levels. The claim is there to basically tell the story of the patient. The diagnosis or the CPT HCPCS code is explaining what happened, and the diagnosis code is telling the story of why it happened. So why the patient is there and what they did to help this patient. Did it change?
Yes, it did.
Okay. So payment for an FQHC PPS claim is made by comparing the adjusted FQHC PPS rate to the total submitted covered charges reported for the specific payment code. So those G0466, G0467 codes. The national rate is $110.16. The GAF, or the geographic adjustment factor, is based on locality, or based on the locality that is applied. So you can see the chart that's listed here. It'll list the locale and their associated 2023 FQHC GAF factors. The annual wellness and the IPPE are paid by Medicare on that G code. at the FQHC's billing charge or the annual PPS rate maximum, whichever is less. And in this case, coinsurance is not applicable. So payments to FQHCs. FQHCs are paid at 80% of the lesser FQHC charges or the FQHC PPS rate for the specific payment code, which is the national encounter-based rate with geographic and other adjustments. The FQHC PPS base payment rates are annually updated utilizing the FQHC market basket. And coinsurance is 20% of the lesser of the FQHC charges or the PPS rate for that specific payment code, except for certain preventative services. Coinsurance and deductibles are waived for certain preventative services, including those Medicare wellness visits. Telehealth are the only services billed on FQHC claims that are subject to the Part B deductible. Incident to services. Services and supplies furnished incident to physician services are limited to situations in which there is direct physician supervision of the person performing these services. So incident to services are commonly rendered without charge, or they're included in the FQHC bill. They're commonly furnished in a physician's office or a clinic by a member of the FQHC staff under the physician's direct supervision. Drugs and biologicals that are not usually self-administered are, and Medicare covered preventative injectables such as the influenza and pneumococcal. Bandages, gauze, oxygen, and other supplies are included. And the assistance by auxiliary personnel such as a nurse, a medical assistant, or anyone acting under the supervision of the physician. Just as a note, direct supervision does not mean that the physician must be present in the same room. It just means that the physician must be in FQHC and immediately available if needed. Incident to services are considered covered and paid under the FQHC. They must be bundled with the FQHC encounter as they are not separately billed or billable or payable. Services that do not occur on the same date as the encounter can be bundled if they occur 30 days before or after. The effect on payment is an increase in the charge and therefore in the coinsurance, and the cost of these services are included in the cost report but are not separately payable on claims. So some examples of non-encounters or encounters that do not warrant medical necessity would be injections, suture removals, dressing changes, prescription services, and blood pressure monitoring. So your influenza vaccine, which is G0008, and your pneumococcal vaccine, which is G0009, and their administration are paid at 100% of reasonable cost through the cost report. Let's see. They are informational only, but it's obviously important to have these on the claim as that tells the story as why the patient is present at the FQHC. Reporting these charges on the claim, or report these charges on the claim if furnished as a part of an encounter. And in these instances, the beneficiary coinsurance and deductible are waived. So for Hep B, the cost of the vaccine and its administration can be included in the line item for the otherwise qualifying visit. A visit cannot be billed if vaccine administration is the only service provided. And hepatitis B should be reported on the claim and is included in the claim payment. These services will be carved out of the coinsurance calculation. So for well woman exams, Medicare does not pay well women exams. Those are those 99381 through 99387 codes. instead an annual or subsequent wellness visit, the G0438 and the G0439, which are some codes that Stacy talked about earlier. Those are reported in place for the examination, plus the breast and pelvic exam, which is G0101, and the pap smear, which is Q0091. So here you can just see an example of the claim that would go out. So it's those rev codes 0521, and then all of the necessary codes. So coding for a subsequent annual wellness visit, the G0439, the pelvic and breast exam, the G0101, and then the pap smear for Q0091. Important to have all of those on the claim, since you can't bill for the overall well women exams with the 99381 codes. So it is important to have all of those elements listed out. A note here is all preventative services are listed to capture quality measures and to report utilization to Medicare for COB. The patient is not responsible for any coinsurance or deductible for these Medicare preventative services. So we do have some other resources available to you. Majority of them are CMS, or I think all of them are CMS resources, but they were just really great links and references to save and have on hand. I know just for me personally, the CMS FQHC qualifying visit list is the best. I have it printed out and it's hanging above me right now just so I can reference it as needed. So just some really great resources available to you. Utilize them. They really help.
Very good. Hey, Caroline.
Yeah.
I did find some references on the modifier 59, the question that was asked about chronic care management. And this also would apply, I think, to the behavioral health management as well.
Okay.
This is in the Medicare claims processing manual, and it speaks specifically to modifier 59. So it says, and I'm just reading this directly out of the manual, the FQHC reports modifier 59 when billing for a subsequent injury or illness. This is not to be used when a patient sees more than one practitioner on the same day or has multiple encounters with the same practitioner on the same day, unless the patient subsequent to the first visit leaves the FQHC and then suffers an illness or injury that requires additional diagnosis or treatment on the same day. So I misspoke when I said it would apply to a mental health and a medical on the same day. It also says modifier 59 is the FQHC's attestation that the patient subsequent to the first visit suffers an illness or injury that requires additional diagnosis or treatment on the same day. Modifier 59 should only be used when reporting unrelated services that occurred at separate times during the day. So this is directly from the Medicare claims processing manual.
Gotcha. So in that case, specific to behavioral health, if the patient came in for an annual wellness and saw one physician and then came back and saw their psychiatrist, you would not append modifier 59.
Right.
Right. Okay.
And the same for chronic management, chronic care. Because
So
because those CPT codes that you're reporting is going to identify those separately.
Right. So another question from Jamie, maybe in a crisis situation only, would that modifier 59? So in that case, I do think, and Stacy, correct me if I'm wrong, but like if they went in initially to see their psychiatrist for their normal visit and then suffered some type of crisis after the fact and had to report back, they saw the same physician, they're both qualifying mental health visits. So in that case, the subsequent, you would apply that 59.
I would apply, yeah, I would.
Okay. I hope that answers your question.
Yeah. Any other questions that anybody has?
I don't see any. If you have any, please feel free to drop them in the chat, or if you think of any after the fact. let Caleb know. We can answer whatever.
Any questions regarding telehealth? We do know that FQHCs, can provide telehealth services. And, there's just a modifier. I think it's is it the G2025, which is the telehealth code. I know this is not in any of our slides, but the questions that we get most often, even though it's post PHE, there's still telehealth services happening pretty routinely. And so we still get questions around, what are the documentation requirements? And I can tell you really there are four main bullets, if you will, when you're documenting for telehealth services. So you're going to document as if that were a face-to-face encounter, as if I were sitting in the room with the provider, right? You're just going to document that as normal, noting, that you may not do, you're not going to be able to do a physical exam or take measurements or something like that. But you need to document that you got the patient's consent to agree to the telehealth service. You need to document what platform you're using for that telehealth service, whether it's audio and video, is it audio only? What's the platform that you're using? And then you need to document the patient's location as well as the provider's location. So those are really the four main things that need to be documented in order to meet those telehealth requirements and their criteria to be able to report a telehealth visit. So I know it's not in this slide. We're going to talk a little bit about post PHE in a couple of weeks, I think. But we just had a few extra minutes here, and I thought I would just kind of throw that out there if anybody was sitting out there with any telehealth questions. So
Yeah, and
I don't know if that triggered any questions or anything.
Yeah, it did. One question did come through. Mike is asking, are there any changes in relation to FQHCs providing remote patient monitoring post PHE? Right now, it is not possible, correct?
I have not seen anything. Yes, that's correct. I have not seen anything yet on that. I've not seen any changes. I know that's a hot topic right now, though, the RPM. So maybe, but right now, no. Okay. Any other questions or comments or Caleb, anything from your end that you need us to address or talk about?
Not that I can think of right now. I'm going to go ahead again. And as always, we've got to get that knowledge gained post-polling question in there. So I'll go ahead and launch those. And if we have any questions as we're wrapping up here, feel free to ask. Any more questions? Great dialogue today. I really appreciate all the questions and engagement. It's awesome.
Yeah, we love it when we have questions.
Okay, if there are no more questions, I just want to echo what Caleb just expressed. Thank you all for all the wonderful questions and the engagement. And make sure that you complete the post polling. And I hope to see you all next week on the part 3 of our series. And thank you all again for joining us.
Thank you very much. Bye, everyone.
I do see one more question.
Yeah, I was just about to say, and I did, Mike, I did like screen grab your question. And we'll definitely get that sent back out to Caleb with an answer, and he can forward to you. So we will look into that. Perfect. Thank you.